So it's my pleasure to introduce a friend and colleague, Mike Sisti. He's the McMurtry Professor of Neurosurgery, and his title of his talk is The Surgical Consilience of the Optobioelectromechanical Electro Treatment of Surgical Treatment of Glioblastoma. And Mike, I put in a trademark for that term already, okay?
I thought you were going, Dean. That's okay. That's all right. We'll go, I'll go next. Yeah, no problem. Yeah, it's all right. That's okay. I'm always ready. I was born ready. Well, thanks for that nice introduction, and hate to spoil your little spine party here, but I am a disruptive person. But disruption is key. In fact, if I had to take a theme from all the talks I've heard, which have been amazing since the last time I did spine, it was Harrington rods and clamshells, just to see the advancement and change. And everybody's been pointing out that if you just keep doing the same thing over and over again, nothing will change. It's the definition of death, because Schrodinger defined life as the resistance to equilibrium, and I'm feeling that here today. And so it's been really inspiring to see the experience and the change from where I remember spine to where it is now. This is a first for me. I've been doing this for a long time, and I've never actually given a talk on surgery as it relates to glioblastoma. But within the last year and a half or so, one of our young attendings, Brian Gill, who will be speaking tomorrow, has been pumping me with all kinds of new ideas and things, and two of them, I think, have changed my entire repertoire to the approach of this tumor, of which I participated or done over 1,000 brain tumors, primary brain tumors over the years, and I'd like to share that with you a little bit. So part of this is the humanistic side of this. Spine problems are largely solvable, but of course glioblastomas all have the same outcomes. And really, in the absence of a cure, what we're doing with glioblastoma is we're treating the survivors, we're really not treating the patients. It's the secret to taking care of brain tumor patients, is you take care of those people. It's the doctoring I do as a neurosurgeon. And there's value in that, even though that's not the outcome that no one wants. But the solution, as many people have pointed out today, is in better tools and better technology. And that's not going to come from us thinking. It's going to come from products and ideas that are coming through technology. When I started medical school in 1977, there wasn't a CT scanner in New York City. And when I finished my residency in '88, we had 1.5T gadolinium MR. And so it's always the technology that leads the way. And I've been using ChatGPT and Anthropic's Claude to make some of these photographs. And Richard Bartigan, some of you, what's all watched over by the machines of love and grace is a poem he wrote in the 1960s about the genesis between cybernetics and human beings. And I took this obviously from the Sistine Chapel to say that there's going to be a fusion at some point of our life. Kurzweil says it's 2040. I think it'll be sooner than that. For Gen Zers who are here, but probably don't know this person, this is the last of the New York City beat poets. You might know him because he wrote a book called Watermelon Sugar. Henry Styles took that up as a song. It's about the apocalypse and a dystopian community that centers around a commune called the I-Death. And this was written in 1967. But he was a futurist, and he thought man and machine would merge for grace. And I think that's an important point. So consilience, does anybody know what this word means? I didn't know until 2009. Somebody gave, you know? Didn't I tell you that in your office? I love Ray Sekula. So somebody gave me a book in 2009 from, and by the way, my title, I'm using my PGY titles. This is exactly correct to today. I'm PGY 44.24. Whatever else I am, I'm really just PGY 44.24 as of today. And so consilience came to me from an entomologist at Harvard named Emerald Wilson. Some of you may have read some of his stuff. He's a guy that learned a lot from watching ants. And he wrote a book in 2009 called Consilience, and somebody gave me that book. And it's a sweep of thought from Athens to current about rationalism in science and how different fields can interact, not just scientific fields, but economics, sociology, art, philosophy. And it was a unit of knowledge to give you a better idea about what it is. The word was actually coined by, of course, by an English polymath, William Whewell. Nobody knows who he is, but he had a big influence on Darwin. Darwin used this word in Origin of the Species on the first page, and it means unity of knowledge. And here's Edward Wilson. Learned a lot from ants. And the idea is just take different ideas, not your ideas necessarily. They're not original. In fact, nothing I'm going to talk about today is in any way original. I just took ideas from other people and in this little project tried to combine them to get a better understanding of how to become a more skillful surgeon. This is not about treating glioblastoma. It's about surgical skill. And skill is a combination of speed and accuracy, like Frank's talking about that. And if you want to do things better in surgery, you need better tools so you can be more accurate and you can be faster. And this has happened. Like I said, I've done a lot of surgeries, complex ones. But if anybody had told me 3 years ago I'd be doing this better today than I was then, that would have been pretty shocking. I don't expect anybody will do any of this. Everything of this is off-label. I have no conflicts that pertain to neurosurgery, but I'll share with you what I've learned a little bit. So Consilience, unity of tools. And tools are important, and I'm going to touch on this a little bit. And I just coined this word of optical, everybody knows this, optical fluorescence, could be fluorescein, could be 5-ALA, biological activity is very important for tumors. Everybody knows about stimulation, either cortical or subcortical, and eventually you got to take the tumor out. That requires a mechanical thing. So what if we took ideas from each one of these disciplines and tried to make them consilient? And this is a riff from Wilson's book where he shows different kinds of fields in a graph in 4 quadrants, and he draws circles around them to say there aren't really barriers. There's a lot of permeability, and if you can take these ideas and join them together, perhaps they don't add, they may multiply. Some of you may have read A Rational Optimist by Ridley. He describes this as ideas having sex, right? They multiply, they don't add. And so I think that that's true. So one of my great influences when I was in high school in the 1960s, I followed this person very carefully, still alive today, Stuart Brand. Before there was the internet, there was something called the Whole Earth Catalog. In fact, Steve Jobs, in that famous speech he gave at Stanford graduation in 2005, called this Google before there was Google. You know, in the 60s, there was no information. But this 2.5-foot-long book with super thin pages were a series of web pages about tools that would allow you, if society collapsed, to live off the grid. And it covered everything. Any question you ever had in high school would be answered in this book. I don't have the first edition. I have the second edition. The blue marble he got from NASA by torturing them because he had heard that a satellite in the 60s had taken a picture of the entire Earth. It was secret, but he got it released, and that's why it's called the Whole Earth Catalog. And to show what a disruptor he is and how creative he is, his current project, which is being built by Bill Gates, is the Clock of the Long Now. It's a clock that will maintain time for 10 millennia, 10,000 years without human intervention. So once you have this kind of thing, and why does he look like that? It's to reduce status. He's a disruptor. He's a creator. He's an out-of-the-box thinker, and he always presented himself this way. And he was the nexus in the Bay Area between, he's a biologist from Stanford, but he was very involved in computers, between Haight-Ashbury, you know, the hippies, and LSD and drugs and all that time, and technology. That was one pole of the change in the 60s. The other pole was, of course, right here in New York in the East Village. And all their ideas turned out to really still be pertinent today. So obviously we can't cure GBMs. I say the surgical strategy is simple. My residents hear me say it all the time. Brain good, tumor bad. Everything else, just a lot of details. Show me the man. Okay, that's from the Prayer of Maimonides. And so each person doesn't really get the same treatment. Every person you deal with, especially in New York where you have the entire world here at every epoch of its age, you have to titrate your goals of surgery to that person, their family, and their own personal situation. And so there is it seems inconsistent, but it's a consistent inconsistency. And if anybody knows anything about art, that's what abstract art is. There's harmony in that inconsistency when you apply it to people and not objects. And so I changed my repertoire. It seems, I'll show you something on this later, but you have to know the person who you're operating on to know what's right to do. And obviously, everybody knows the more malignant tumor you take out, the better it's going to be. Somebody said today, I think it was Mike, time is our most precious commodity. And so if you can do things faster and better, being skill, speed, and accuracy, you know what this leads to. You're the beneficiary. This is fun. You enjoy yourself. It's beautiful. It's joyful. It gives you grace. And the grace comes from using better tools, as Bardigan said in his poem. This is a classic win-win for everybody. So seek beauty in all things by becoming skillful, and that pertains to every phase of life. And this concept, which residents hear me talk about, was coined in 16th century Italy in Florence by Baldassare Castiglione. So the telos, which is the purpose or goal. It's a Greek word for GBM, which is an absurd cancer, okay? Anybody who's dealt with here knows the absurdities of this disease. And so part of it is your skill set, which is, to quote my mother, nobody wants brain surgery. That is true. Barbara Kruger is a post-feminist graphic artist, does these kinds of red-black things. I saw, therefore I am. But outside any neuro ICU now in the country, you've seen this picture. You see this every day. You see the absurdity of the glioblastoma. They're waiting for something that's never going to come. They're waiting for Godot. And really, one of the points of that absurdist book, which is a masterpiece, is that you're never going to get it right. You're going to fail, and you're never going to succeed. You're just going to fail better. And I think that's where we are right now with this. And because I kind of think of my engineering background, the equation for a GBM, of course, is kill times consume times multiply equals conquer. And so, unfortunately, that's where we are right now. But I think with the advent of AI and better tools, I think we'll make more progress in the next 10 years with data centers of geniuses than we made in the last 100 in this disease. Neil Felstein's dad, anybody? Does anybody know where 5-ALA comes from? Does anybody know the origin story of 5-ALA? No. Well, there's a biochemistry of it. You know, 5-ALA is one of the oldest molecules on the planet because it's a key to terrestrial life, because it's a photophore, it's a precursor in the porphyrin pathway to chlorophyll and hemoglobin. That's what. So David Schimann, of course, he's a New Yorker. He goes to City College. Yes, P&S. He's a professor of biochemistry there. He actually gets his biochemistry degree. You can do this in the 40s. He swallowed glycine, a precursor to 5-ALA, was tagged with radioactive nitrogen, and he draws his own blood. He's his own, no IRB. He just draws his own blood over a couple of days, and he publishes the biosynthetic pathway, which is still correct to this day, in 1945. So, and this can enhance your surgical skill. This is part of that OBM thing. So, optical bio, this is an interesting picture, right? So, actually, because my residents who are here, some of them know that I'm a big stickler on surgical ergonomics and posture and surgery. I'm very well known for adjusting people's posture while they operate so they can be comfortable, still, and precise. And so here I am standing up in my usual posture. Notice no microscope, and I'm using, obviously, a cautery in my right hand. My left hand, I'm using a Fukushima suction, the way Taka Fukushima taught me to use it. But you notice some light coming out of it. Does anybody use a suction that has blue light in it? Good. All right, so you've just learned something today you can do that you didn't know about in this before you got here. Okay, Brian put me onto this one. Actually, Randy D'Amico wrote one of our ex-residents wrote a very good paper in operative neurosurgery about taking red rubber catheters and sticking them on teardrop suctions. I wonder where that idea came from. And then hooking them up with an alligator clamp to electricity so that you could have something the equivalent of what everybody knows we use in acoustic surgery. I use the Cartouche system, which is a dissector and a stimulator to monitor facial nerve. It's highly efficient. It dissects and stimulates simultaneously, and it's accurate and precise. It makes you faster, better, and safer. So what if you had an insulated suction that did the same thing? Well, suction obviously is mechanical removal, and if you want to reverse polarities, you can do cortical and subcortical stimulation with your most important instrument. I'm right-handed, your left-handed instrument, because a suction is a dissector, it's a retractor, and it's a suction. So it has many functions. So you don't have to ask a nurse for a lot of things. You can flow with the surgery in real time. You want to really be checking MRI scans, ultrasound, stereotactic guidance, or do you really want to know where you are subcortically in the resection of a glioma? Well, you can waste time doing a lot of things that's not going to change the outcome of the surgery, but what if the tools you were using could guide your way? So surgical skill, speed, and accuracy. This is beauty's in the eye of the beholder. And so the way I kind of look at this is everybody here uses transportation, but not everybody here is driving. It's the same way. Everybody here needs to eat to survive, but not everybody dines. Everybody here is the product of reproduction, maybe even in vitro. That is not sex, okay? So it depends upon how you define quality. And so I think that's your idea of grace or joy or beauty is personal to you. And, you know you've married the right person when she tells you that sell the house and buy the car. That's apocryphal. I see Jonathan here. It was actually a painting, and we still have a roof over our head because we didn't do that, but we probably should have. In any event, the secret to this surgery, of course, is a touch surgery. And John Keats, the poet, said touch has a memory. And this is why I don't like using heavy instruments with inertia, because I find that instruments that vibrate, or like the Cavitron or Sonoped, even the Nico to some degree, the vibrations affect your fine touch. And touch has a memory. If you remember what things feel like and you can see actually what they are in, in a truthful way. You see reality for what it is. The combination of a gentle touch and a truth-seeing eye is extremely helpful in surgery because that's how you get the surgery done. And so notice here, you're seeing 4 hands and 7 tools. This is a rift from when I was a chief resident with Ben Stein and worked with him till he retired, doing a lot of impossible things that couldn't be done. They could be done today, but not in the 80s and the early 90s. That particularly in AVMs, we would start surgeries by bridging the microscope and working 2 surgeons together, 4 hands with multiple tools to do the cortical parts before we got to the deep white matter, thalamic or brainstem parts. We don't really do that anymore, but it was interesting as a proof that 2 surgeons working together simultaneously, as opposed to being blocked out with a microscope. You could do this obviously with, with a Orbi kind of scope, but we have to set that all up by ourselves. So if you have an exoscope, that'll work perfectly fine. But we don't really use that very much, although I would if we had it. And it was good. You can work with multiple hands and tools at the same time. You'll be faster and better. You can add anything else you want to this. It doesn't really matter. From tractography to intraoperative imaging to ultrasound, that's really not the point. So here's the electrical mechanical part. So I'm in the middle one. I'm the 7th tool there, because the tool would be suction, electrical stimulation, the laser, meaning the NICO, which has a laser on it, the 5-ALA laser, stereotactic guidance, and any other tool you want. And the interesting thing is, in the NICO spectra, there's the laser there, which is extremely fragile. You can cut it off the housing with a number 11 blade, and there's a separate tube to hold the laser there, which you can take the laser out and you can put in any instrument you want. Because the problem with biological, optical things in surgery is you can't get sufficient flux of light. Flux meaning the intensity of the light, the energy of the light per square surface area. With a microscope, it's just not enough light. But what if you could put the light right on top of your subject? You know, with the 5-ALA, the more you use it, the more it fluoresces. And in fact, it fluoresces quite a bit beyond the gadolinium margin, which is why perhaps stereotactic guidance is not as important to me as it once was in the deep white matter of the brain, because using these tools in combination, and there you see on the right-hand side, you see a teardrop suction, and I've threaded the laser through the teardrop. So while you're suctioning, while you're dissecting, while you're retracting, you're also emitting light. And that light shows you exactly where the tumor is, because that's its biological activity. It also allows you, I say translational research to me is taking the tumor and putting it in a cup and giving it to a smart person. But how do you do that? Do you have to give them the right piece? You have to know where that piece is, and you have to know that that piece is actually metabolically significant, not a piece of necrosis, which you see in GBM. It'll screw up everybody's research. And people who work with me in the OR know I spend a lot of time getting these specimens to the right people in exactly the right way, because garbage in, garbage out. You give the research team brilliant people working day and night trying to come up with better answers, and you give them crap, and there's nothing can come for that. I always say we don't want to ruin somebody's opportunity to get a Nobel Prize. And so you can thread the laser right down the light. You just have to be careful how you do it. It's very fragile. And so here's just some options of that. You can actually, the dry touch comes in a 7. They're too long. They come in 7 French and 10 French, and you can actually tape them onto your regular suction. You can use 3 suctions at once in one hand. That's what I'm doing on the right side. I call it triple suction, because sometimes I want a bigger suction, and sometimes I want a finer one. And I don't like anybody to ask. I like to have everything in my hand at my own disposal. And you can see the light being admitted there. I'll show you some better pictures. Here's actually how the NICO spectra comes. I have nothing to do with this company other than apparently I was the first person in North America to use it. You can see the NICO, but on the NICO is the laser, and the thing above it is an extra housing. So if you take a number 11 blade, you can slice the housing off the NICO and use it as a plain NICO, or you can, if you feel confident enough, you can take the laser out and put it down the second channel that they give you, and you can tape that to anything, any instrument you want. You could tape it to a cavitron, you could tape it to a suction, you could tape it to your cautery. It doesn't matter. You can put it any you want. And that's an overview of what it looks like. It's hard to see. The suction is at the bottom, and you can see the fluorescence. And this is somebody standing behind me with an iPhone. That's how great the fluorescence is. And all you need to know is the red stuff is the bad stuff, and the stuff that's not red is the good stuff. This allows you to operate in areas that we used to operate in with AVMs. Pat Kelly was big into thalamic glioma surgery in the 80s, and that really never went anywhere. But I'll show you some things that I've learned I took from my AVM experience of the last century, and realizing with this technique, I can enter into functional areas and not cause functional deficits. And so this is my most common way to use it. I've got the dry touch suction, which is continuous subcortical monitoring. The number of millimeters that you get from the milliamps that you have tells you how close you are to critical structures, particularly motor structures. It's very precise. I have excellent monitoring people that work with me in a posterior fossa surgery, and this is sensitive and specific, at least in my hands. And I've just taped it onto my suction. So just some examples, simple ones, you see the very large superficial GBM, but what about that little thing that's hanging off the side, the hanging chads, I like to call them? It's not so easy to find in the deep white matter just outside the ventricle. But with 5-ALA, and you want to know where you are, look, laterally you can find the retrolenticular capsule, internal capsule. You usually, in something like this, it'll probably be 10 or 15 millimeters from where you are. And if you use it every time, then your team, your nurses, your monitoring people, and yourself will begin to understand intuitively the relationship between your anatomic position and functional tissue in white matter, where everything looks the same outside the tumor. And it's becoming more natural to me as I'm using it more and more. Like a lot of new toys that you get in technology tools, the more you use it and the more the people around you understand how you use it, then you share that knowledge, and the knowledge that is shared gets better faster. And so that makes you more efficient, more skillful. And we've been hearing about that all day today. So this is a little trickier, right? Because again, this is not a difficult glioma to remove, in the white matter part of the left parietal lobe. But what about that part in the thalamus? And what about that part in the angular gyrus? Well, I'm not very keen on taking things I'm not ready to quite go there yet. I'm already causing enough trouble by going in places I shouldn't go. But I wasn't intending to do anything with the thalamic part. But here's a little serendipity. On the postoperative scan, you can see I've got a nice resection of the easy part to take out. You could do that conventionally. But I also managed to get into the thalamus without recognizing it because I didn't use the microscope. I did this with loupes. And I went in and I just followed the 5-ALA fluorescence with my laser on my suction and my stimulator, because here I got within 3 millimeters of motor function. And when I did the post-op scan, I was shocked to find that I took out the thalamic part. It reminded me of some of the AVMs I used to do in the posterior thalamus with Stein. And I intentionally left the angular gyrus portion alone because his speech wasn't great and I didn't want to make it any worse. And there are other, we're not trying to cure him with this, it's just trying to take the maximum safe resection. But this was serendipity to me, and this sort of got me thinking that, hey, maybe in the motor strip or maybe in the speech area, if I could discern metabolically tumor tissue from functional tissue, maybe the same way you did AVM surgery, you could translate that to GBMs. That's a work in progress. Mike Wang talked a lot about speed, okay? So this is not a difficult surgery for a brain. It's a recurrent brain tumor. It's superficial, it's temporal, it's occipital, it's right on the surface, no problem. And I use the same thing that Wang uses for time. Once the anesthesiologist is done with the patient and we're prepping, I look at from prep time to the patient in recovery room in ICU. And so, and look, this is a large tumor, but I took this right to the internal capsule. You can see here the confines, the extent of surgical resection, and the whole thing was done in 148 minutes. I mean, and this patient looked better after he looked pretty bad before the surgery. Of course, it's not going to change his outcome, but as a proof of principle, the superficial ones you can do very well. Now, not everything goes well, and this is a learning curve, so you make some bad mistakes in this, and here's one that I made. This is a long-term survivor of a low-grade glioma in a young man. Many of my residents know this patient. I first operated in 2011 with that small thing in his left frontal lobe. It was a low-grade glioma. Came back in 2023 as a GBM. That's the cavity of the resection, pretty straightforward. And in 1 year, this guy's 36 years old. He had a seizure in that 2011. His brother was ejected through the windshield of a car, hit a tree and died. And these are the only two boys in this family. It's a real tragedy, of course. And he had a massive recurrence of his tumor, and so said, look, this is the last stitch, right? This is the last thing. Dominant hemisphere, corpus callosum, right to the angular point of the insula, right up against M3 vessels. And I decided to really push this, and you can see in the CT scan, I knew I was going to get to branches of the callosal marginal, and M2 or M3 branches of the dominant left MCA, but I figured, okay, they'll just go into the NICO like they usually do, and I'll just put small wet clips on them. What's the problem? And there was a problem because this is a multiply recurrent radiated clinical trial kind of GBM patient. Blood vessels are not normal. Sometimes I see that in medial temporal lobe resections where you get a problem with the choroidal artery, even though you never see it or never cauterized it. And unfortunately, postoperatively, he developed an ACA and an MCA infarct from which he never recovered and died 6 months later. And all my surgery did was prolong his agony and the agony of his family for another 6 months. He probably would have died within weeks of leaving this alone, but the circumstances were such. But as a proof of principle, the corpus callosum part is gone. It's down to the A2s. And I'm into the insula right at the point of the M2 vessel anterior in the insula. And I could, with 5-ALA and subcortical monitoring, I was able to map this very easily and quickly. But it was a very bad result. And so there's a learning curve. So when you add together skill and consilience, you get sprezzatura. Sprezzatura is an Italian Renaissance concept from the Medici who employed Baldassare Castiglione to write a book about manners and class for finance people in 16th century Florence. They had a lot of money, but they wanted to be aristocratic. And so, and the key thing he defined for an aristocrat was to make impossible things look effortless. And so, like there was nothing. The literal interpretation means to toss off. So the concept of making something appear difficult or easy or effortless, because all obvious effort is the antithesis of grace. And so what we're striving for is to be David L.M. Renato. Renato is a Latin word that means born again. We'll be something like David with mechanical and artificial implants. But on the right-hand side are all the things I go through in every surgery multiple times. It's like a cycle. There's a riff on, if anybody knows the Dead Kennedys, punk rock grew from the 60s and 70s in California. Chicken-esque conservative. I just play on this because sometimes I'm a chicken in surgery. Sometimes I should be more of a chicken. Sometimes I'm changing my my approach like a chameleon, and sometimes I'm pretty annoying and I'm Dr. Killjoy, chicken-esque Killjoy. So, you know, I'm trying to use this to get better at what I do as a surgeon for a disease I can't cure surgically. It's surgery. It's not an operation, in my opinion. But I think it's a worthy thing to try and use these tools in a coordinated, consilient way to do better for patients and to do better for yourself. You can learn something. I mean, here I am, you know, 44 years into this, and I think that's the idea about how long you should be doing this. Are you disrupting? Are you changing? Are you getting better? Or are you just staying in place? Schrodinger said it, you know, life is the resistance of equilibrium. And I think everything I heard today just plays into that. So when you get that, then everything is beautiful. And here's Baldassare. You know he's a player. He was painted by Raphael. If you go to the Louvre, it's in the room right across from the Mona Lisa. It's a better painting, actually. Leonardo was very jealous of this painting for many reasons, and that's why he carried it with him. There was a little competition there, just like in surgery, of course. They were phenomenal painters and artists, and they could make you feel what they felt. And so, you know, maybe as a man, we'll be made of stone, meaning we're strong, and then we'll also be intelligent with it. So, Brandt, his final publication, the opening sentence to the Whole Earth Catalog is, "We're as gods, we might as well get good at it." And he's changed it to, "We're as gods, and we have to get good at it." And I think that's a good mission statement for neurosurgery. We have a lot of power over the lives of people and their families when we're deciding what to do, how to do it, and how much to do, and under what circumstances. It's not godlike power, but it's pretty close. And so we have to get good at it. So this is called the whole earth discipline. And so, of course, this is a riff from, you know, Tom Wolfe and the Kool-Aid acid test, but he called this, Stuart Brandt drove the bus, by the way, which is called Further, which is a play on the word. And so I thanked all my residents who I've been torturing for the past year and a half to convince everybody in the OR that spending all this time and slapping all these instruments together with the physiology people is worth our while. And I think it is worth our while. And you give me a tool, you give me a frame flower, that is me. If that could help, I would use it. So I really appreciate that. And because last week we had the Ellsberg here in New York, I had a chance to see a lot of my ex-residents there, most of them P&S grads and trained at Neuro. And so to all the lost boys, because there were only boys there, everybody, I didn't see any of our other residents there. To all the lost boys of neurosurgery of New York City, just keep going. That's the message. Thank you very much. Oh, yeah. Yeah, go ahead.
With all of your experience, we have a lot of, beyond what you've shared with us today, we have a lot of medical students and residents in the rooms. What would you be thinking about in terms of where you'd be heading in the management of glioma?
Yeah, I'd be heading in AI. I mean, I think, my generation is, imaging and it was really all about imaging for the most part. But I think this generation, it's AI, robotics, and genetics. And I think genetics is beyond the scope of neurosurgery. I think that's a primary scientific discipline, which you need to dedicate yourself entirely to. Can't dabble in that. Robotics, robotics, I think we have a lot to offer, and spine's been leading the way in that. And I think, I played with Da Vinci, by the way, the fourth level, the fourth generation Da Vinci. We've had it at Neuro. Some people have seen me out there trying to toy with the Da Vinci, doing suturing and touching things. And it's remarkable how good the haptic feedback is. It's too slow for the brain yet, but certainly that's going to get better and better. So I think robotics and, of course, AI, because all brain tumors, we have tons of tissue all over the place. I mean, I don't know, I could ask Jeff Bruce how many thousands of tumors we have in our bank. And so that data, once shared in a global way by very sophisticated computer programs, is going to start finding things that no human mind can conceive of. And it'll probably make suggestions about directions that no one's thought of yet where to go. Because the thing about a good tool, like a hammer, a hammer, you don't know how to use it, you'll hurt yourself. But you know how to use a hammer correctly, you'll build St. Peter's, okay? So if you're a knowledgeable person, like many people here, at all levels, and you know how to use tools, and you're given a superpower tool, I don't care whether it's a CT scanner, an MRI, subcortical stimulation, 5-ALA, continuous subcortical stimulating, whatever it is you're doing, if you get a better tool, you're not going to solve all the problems. It'll be waiting for you'll fail better, but you'll have a better problem to work on. And that's what we're all here for.